Thank you. And the recording will be posted on the committee's webpage shortly after the meeting. And Pam McEwen, FTech Liaison to the Universal Healthcare Commission, will now call the meeting to order. Pam?
Thank you, Angela. Welcome, members. It's now a little bit after 2. And I want to call us to order. I want to begin with an acknowledgement. I am coming from the very frigid Methow Valley, where we have sub-zero weather right now. And I want to especially acknowledge that this is the land that was traditionally inhabited by the Methow tribe, and they've been good stewards of this land since time immemorial. And as usual, I want to begin with a overview of the agenda. We'll begin with the roll call, and we usually begin this with an icebreaker. I have an old version of this, and I'm not sure what the icebreaker question is. I think it's, what are we most looking forward to in 2024? Okay.
Yes.
Excellent. Right. And then we will vote on the November meeting summary, followed by public comments. HMA is going to share the Commission's 2024 work plan and updates from their last meeting. And then today's meeting is going to be building on the Medicaid discussion. And we've had kind of a gap of time between our Medicaid discussion, so we will have some time for reviews and catch up. We're going to be hearing from Dan Muse on waiver options to integrate Medicaid, as well as some of the federal barriers and other considerations that come with those possibilities. And then we'll be hearing from Michelle Needham on Washington's experience with 1115 demonstration waivers. We're going to implement a really innovative thing, which is we're going to actually give you a break after Michelle's presentation, probably for 5 minutes. And then Stephen Spivak will then provide an overview of some of the barriers to access for Medicaid enrollees. We're going to have 30 minutes for committee discussion, and there will be time after each presentation to ask questions for discussion. And we'll have a review of the questions that we need to have in mind, so you can have those, bear those in mind as you listen to the presentations and kind of bring that into the discussion in the Q&A. As always, I really encourage all the FTech members to ask questions and provide feedback as we go along. I'll turn it over to Angela to go through our roll call.
Thanks, Pam. So I'm going to go ahead and go through roll call, and please remember when your name is called to let us know what you're most looking forward to in 2024, and I will start with Pam.
In addition to looking forward to the temperature rising again here, so I can go outdoors again, I have some travel planned in Japan this year that I'm very excited about. Looking forward to.
Have you been before, Pam?
Never. I'm very excited.
Oh, how exciting.
Yeah.
That's awesome. Excellent. Christine, I think I saw you join.
Yes, I'm here. And I think I'm also looking forward to travel in 2024. I'm not sure to where yet, but my family's trying to arrange a trip right now. So. Yeah.
Oh, exciting. Nice. Thanks, Christine. Next, David.
Hello, everybody. Looking at your background, Angela, it makes me want to go skiing. So hopefully that'll happen sometime soon.
If you can make it to the mountain with all
That's
the snow.
right.
Thank you, David. Eddie.
Present. Yeah, I'm looking forward to springtime, warmer temperatures, and exploring a little bit more of the Puget Sound with my sailboat.
Oh, nice. Thanks, Eddie. Esther. Esther? Okay. Ian? And Ian did let me know he likely wasn't going to attend, but just for the record, Ian. Kai? Kai also let us know he wouldn't likely be able to attend. Kai? Okay. Bob Murray, please.
Yeah. Well, here I'm here. I guess just my daughter who lives in Australia. I'm going to go visit her in March and April for 2 weeks. So I'm very much looking forward to that.
Oh, what time of the year will it be for them in March and April? Will that be their
transitioning? It's summer. It'll be fall for them. So.
Oh, nice.
To the extent they get changing colors, I'll be able to see that.
Oh, very cool. Thank you, Bob. And finally, Roger. Roger, if you're talking, I think you could be on mute.
I know Roger's here.
I see him.
My apologies.
There you are.
I was caught off a little off guard today because I was planning on movies. So I'm going to try one what I'm looking forward to this coming period of time is go into movies. And I picked out a movie that folks might enjoy. It's Jeffrey Wright, An American Fiction, that's coming out. So
Oh.
it might be a fun one for us all to see.
Yeah.
Oh, excellent. Thanks for the recommendation. Thank you, Roger. Thank you, everyone. And I will go ahead and turn it back over to you, Pam.
Thanks, Angela. So we have approval of the meeting summary. So please join me in turning to the second tab of your materials. And the recording of the last meeting is posted on our webpage. We will use the consensus process to vote on the approval of the November summary. So first of all, is there any discussion or proposed changes to the meeting summary from anyone? Okay. I propose the minutes be accepted without change. Any discussions on my proposal? All in favor, please say aye.
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 Any
Aye.
opposed? Okay, we're approved by consensus. Next, we're going to move on to public comment. Committee members can find written public comments under tab 3. We will allow individuals to sign up to provide public comment before the meeting, and we will start with those who have signed up to provide comments. When you're called upon, please state your name and affiliation, if any, before speaking. We'll display a timer as a reminder of the 90-second time limit. When the timer stops, please stop your public comment. Angela, would you please start with the names of individuals who've signed up?
Yeah, first we have Catherine Lewandowski. If you'd like to come off of mute.
Sure, great, thanks. Hello, everyone. My name is Catherine Lewandowski. I'm a registered nurse here in Washington, and I'm the co-chair of Whole Washington. I want to encourage you to continue to look at the work that Connecticut's been doing in their Medicaid reform. If you remember that back in 2012, they decided to move their traditional managed Medicaid program to a self-insured managed fee-for-service model. In an article written by Fady and Mandy Seha just last fall, the state did this because they believed that the existing managed care system was riddled with issues like inadequate provider networks, poor care coordination, insufficient oversight, and growing administrative costs. Patient advocates complained about denied services. Beneficiaries expressed their frustration at the lack of access to care, and state officials became disgruntled with health plans' refusal to share data on costs and claims. After canceling their $800 million in contracts with private insurance in 2012, and adopting a self-insured system similar to those used by large employers, they entered into contracts with 3 companies to administer the new plan. The results of this has been a savings of $50 million in the first year, with consistent 2 to 3% reduction in costs year and in administrative savings. Their Medicaid beneficiaries also have seen an improved quality of care, and because of the decreased administrative burdens for providers, there are 7% more providers willing to take Medicaid patients. I'll include a link to that article, and I hope that you will really examine their results closely. These are the types of gains we can also hope to achieve by taking back our healthcare system. Thank you.
Thank you, Catherine. And Pam, we don't have any other folks signed up, but I do want to open it up to anyone who didn't have a chance to sign up and who wants to provide comment. Jen Nye, I'm going to go ahead and promote you now. Once you're promoted, you can go ahead and we'll start the timer. And then I'll also call again, if anyone wants to provide public comments, please do raise your hand and we'll go ahead and promote you. Thank you. Jen Nye, would you like to come off mute?
Hi, thank you. My name is Jen Nye. I live in the 34th LD, and I just read an article in The Guardian this morning, and the headline was, "Majority of debtors to U.S. hospitals now people with insurance." The article mentions there are over 100 million Americans with some form of medical debt. There are so many indicators that our system isn't working. People avoiding going to the doctor, medical bankruptcies, hospitals closing, the exodus of healthcare workers. So many indicators of systemic failure. And with the new year, it's beneficial to remember that that's why we're here. We're not trying to replace one system for another out of some theoretical preference. We need an alternative because we're suffering. It's been 14 years since the ACA went into effect, and we're still dying, going broke, and drowning in administrative waste. In this commission endeavor, we're applying a lot of rigor to universal health care. And while I understand the sentiment of being careful as we proceed, I'm more concerned with being slow, or that we're contributing to a fear of change. Like if we misstep, we're breaking something. We have to remember that it's broken now. So when there are concerns, I hope they're documented with specificity, preparedness, and solutions. How can we measure success? What metrics will we use? How will we gather and data and feedback? And most importantly, what are the resources to correct and improve? We need a real alternative. We're not expecting it to be perfect, but we're expecting an urgent and tangible choice, transparency, and a way to be involved in the transformation. Thank you so much.
Thank you, Jen. I'd like to call anyone else who'd like to raise their hand to provide public comments and just give that a couple of seconds. Okay, Pam, I don't see anybody else, so I think we're good to move on. Thank you,
Okay.
everyone.
Okay, thank you, Angela. So I just want to remind everyone that public comments are really an important part of our work, and I want to thank everyone who took the time to comment or submit comments. And I'd like to welcome back Liz Argent from HMA, who's going to share the Commission's 2024 work plan and some updates from the Commission's last meeting. The work plan is under tab 4 of your materials. So Liz, turn it over to you.
Hi there. Hopefully, can you hear me, Pam?
Yes.
Okay, great. I'm sorry I'm not on camera. I'm in a situation with low bandwidth, and so I just want to make sure that what I'm saying can actually be heard and it's not compromised. So it's a Happy New Year to everyone. It's good to be with you. Just we wanted to make sure that you all are in the loop on what the Commission has been deciding over the last couple months and have a little bit more clarity and information about what you can expect over the next year coming your way. So as you may recall, over the last year, there's been a lot of discussion about transitional solutions. It's taken a long time to actually get to some clarity about where we're going. But we began that work last year and included a survey and conversation with all of you to gather some of those topics. And at the December meeting, the Commission really came together and made some clear decisions about the topics they want to dig into over the next year and how they would like to sequence them. They also agreed at the December meeting about the role of FTAC throughout 2024 and that it should be similar to what you all played during 2023 with a focus on the universal design topics. And the first of which is going to be benefits and services. I know a topic that has that many folks have been, I think, chomping at the bit to get into. Interested. I'm trying to draw more connections between the long-term work on the design of the universal system that you all have been tackling, then transitional are going to be spending their time on, and the topics that are being discussed and deliberated actively throughout the legislative session. So next slide. We go to the next slide. Okay, great. So I don't have the specific work plan to share with you all because it still needs to be approved from the Commission, and that will happen at the February meeting in terms of what's happening exactly and what month.
Liz, you're cutting out quite a bit.
Additional solutions. Here is the, oh, can you hear me, Angela?
You just came back on. If you want to kind of rewind for a little bit, if you don't mind.
I'm sorry. So where did I cut out?
Just introducing this slide in the new groupings.
Okay. Sorry about that. If it happens again, I'll join on my phone. So the Commission spent a fair amount of time in December going through the transitional solutions that were left on the table after they made some previous decisions in the fall to take a couple of buckets off the table because those were things that were being addressed in other venues. For example, affordability, which I know one of the public commenters just raised. There is a big focus on that in the Office of the Insurance Commissioner happening right now. So at the end of the day, these are the three buckets that the Commission settled on, and alignment and regrouping of topics. But the first one is administrative simplification and increasing provider participation in programs. And there are several bullets of very specific top ideas that came forward either from the commission or from many of you in the FTAC that they would like to see tackled under that. And that is the first topic they would like to spend their time on in terms of transitional solutions. The second bucket is maximizing, leveraging, and expanding current programs. This includes things like auto enrollment into Medicaid and no-cost premium plans or lower-cost plans. Expanding or fully funding the expansion for undocumented immigrants that's going to roll out this summer. Increasing participation in the Medicare savings programs, and consolidating and expanding state purchasing. And finally, there were a few others that were left in December that were taken off the list because, again, similar to some of the other decisions that have been made earlier in the fall, developments have happened over the last few months, and these are now being addressed elsewhere, including the balanced billing protection, which includes uncovered ambulance services, and provider rate regulation, which is also being tackled by the Office of the Insurance Commissioner. So the first, again, the first of these transitional solutions is going to be the first bucket, the admin simplification, and the second would be maximizing, leveraging, and expanding. And the reason, one of the reasons we decided to do the second bucket first is because the commission is anticipating, as many in the health policy world are anticipating, a lot more information about the impact of auto enrollment after, I believe, some efforts in California are coming out in April. So that's the plan for the year in terms of transitional solutions. And as I mentioned earlier, the consultant team and HCA is going to be really intentionally trying to make a lot more connection between the work of the transitional policies that they're looking at and the work that you all are doing in the FTAC. And we, really appreciate all the comments and questions that you all are asking to do that, and helping trying to keep us honest with that. So I think with that, that is, I'm done for now. And I will hand it back over to Pam. Angela, did you want me to do this slide? Sorry, or do you want me to do this before?
Well, this
for the
was to
discussion.
sort of, as Pam said, at the introduction,
Okay.
give folks a chance to have a recall of what the commission has asked of FTAC, and some of this was addressed at their November meeting, and then most of these are going to be looked at this meeting today. So it's just for folks to keep in mind as we go through our presentations today.
Sure. So, Angela, feel free to chime in. Just as a reminder, grounder, we looked at this at the beginning and the end of our last meeting together. These are the questions that the commission has asked FTAC to dive into in terms of considering the role of Medicaid in a universal system and a uniform financing system. And one of the questions they had asked was a comparison of benefits for Medicare, Medicaid, and PEB and SEB. And as I mentioned earlier, the next topic on the slate for the FTAC will be benefits, and the commission asked for this comparison, and we plan to bring one to the commission in February and then back to all of you when you begin your discussion, probably in March on this. Next subject area was what about 1115 waivers and what other states have done to expand eligibility, and we're going to hear about that today. And we're also going to hear about Medicaid enrollees' barriers to access, including lower reimbursement rates today. And then these other two topics we will dive into more today in terms of the presentations we're hearing. So I'll turn it back over to Pam.
Yeah, thanks, Liz. That was really helpful to kind of frame that, because we'll be seeing those questions again at the end of the meeting in hopes of making recommendations to the commission. So at our last meeting, we began information gathering on Washington's Medicaid program, and committee members expressed a lot of interest in digging into how Washington might use 1115 demonstration waivers to integrate Medicaid. Again, there was more possibility about waivers in relation to Medicaid than other programs. Dan Muse is joining us today to walk through some of the waiver options, as well as the commission's questions regarding how other states have used waivers to expand eligibility and federal barriers around asset limitations. Dan is the Deputy Director of State Health and Value Strategy at Princeton University and is an expert in Medicaid innovation and state health policy. Dan's presentation is under tab 5 of your materials. Welcome, Dan. Thank you for being with us today.
Thank you, Pam, and thank you to the committee members here for inviting me to speak. My style in this is very much one of like, this is hard stuff to dig through. And so if you need a pause and a review, please use your committee structures to do that. But I'm happy to stop in the middle of the presentation and review so that as you go on, because each slide kind of builds on itself. So as Pam said, my name is Dan Muse. I'm the Deputy Director of State Health and Value Strategies. We are a Robert Wood Johnson Foundation funded program located at Princeton University's School of Public and International Affairs. I am very happy to be here and talk through these waiver strategies and thoughts with you all. So on the next slide, I just want to kind of set up what the plan is for today. This is just a little bit about me. So what I heard from you all is, and what these slides will kind of go through is a little bit on what are Medicaid waivers and what can states do with them. There are different types of waivers, and states have different abilities and authorities under those different waiver structures. What are the limits, both kind of formal and informally, that are placed on states in the waiver process? How do states maintain their dollars and their federal match? How do you think about different populations and different waivers? And what have other states done? And I know that's something that that you all are really interested in. And then I want to kind of end with some thoughts for FTAC to be thinking about as you move forward. So on the next slide, we can start to dig into the different types of waivers. And there are two kind of core waiver programs that Medicaid, and I'm going to start with a couple of acronyms here at the beginning. So CMS, you all know, is the Federal Centers for Medicare and Medicaid Services. They are the federal agency that oversees Medicare, Medicaid, the marketplaces, and a number of connected programs. CMCS is the Center for Medicaid and CHIP Services. That is the kind of sub-center at CMS that oversees Medicaid, and that is where waivers are negotiated and worked through. So at CMCS, they allow two different types of waivers that come from statutory authorities. The first are 1115 waivers, and you hear about 1115 waivers a lot. They're very broad, and they allow states really significant authority to change the way a Medicaid program is administered, delivered, and to whom and how, really. And so those 1115 waivers are structured as demonstration projects. So a state can say to the federal government, we have an idea about how to run our Medicaid program differently. We want to test that and demonstrate to you why we think it works and could be a model for other states. And that's kind of the structure of 1115 waivers. It allows states to receive matching funds for otherwise unallowed expenses in many cases. So Medicaid has a list of things that you can and can't spend money on, and 1115 waivers are an opportunity to spend money that might otherwise not be allowed, or not, at least not be matchable. So you can spend state dollars on it, but not get that federal match. So 1115 waivers allow you to pull that match in. It also allows states to use indirect funds to help with creating that state match. The best example of this is there have been states who fund their public universities to provide nursing programs. The argument is, well, the nurses that come out of those nursing programs serve Medicaid patients, and so we want to allocate a portion of the money that we spend on that nursing education as a matchable expense. And so they kind of count that money as match and then are able to capture on the back end that those federal dollars to then spend on other programs. So that's 1115 waivers. I'm going to dig a lot more into them. But before we get to that, I want to talk about the other side of the waiver world, which is 1915 waivers. And both of these 4-digit numbers come from the sections of the laws that provide these waiver authorities. So 1915 waivers, there are two elements of 1915 waivers, 1915B and 1915C. So 1915B waivers allow for limits in service providers. Generally, Medicaid is a kind of all-comer provider program, so that if you qualify as a Medicaid provider through CMS, which is kind of the same as qualifying as a Medicare provider, then you can take Medicaid patients. There are some states, however, that have said, actually, we want to limit perhaps who the primary care providers are for a group of our patients, because we want to make sure that there's more robust case management. And so 1915B waivers allow for that type of limitation on service providers. 1915C waivers allow for service comparability. And the best way to think about this is, we know that nursing home coverage is covered by Medicaid, but other elements of long-term services and supports, like home nursing care, respite visits, and kind of other LTSS models are not kind of specifically laid out in the Medicaid statute. 1915C allows you to provide those services because you're doing the same type of thing in a different setting. And so those are really targeted waivers that are designed for state specific projects. Next slide. So how do states use 1115 waivers? We're going to go back to those 1115. So 3 big buckets. If federal law prevents a needed service or benefit, so the best example of this is institutes of mental disease. So Medicaid cannot pay for, quote, institutes of mental disease. This goes all the way back to 1965 when Medicaid was developed, and states were funding those kind of state institutions that often housed in an inpatient setting persons with severe and persistent mental illness. Because states were funding them, the feds did not want this to be a transfer of funding from the states to the feds, and so they excluded IMDs from the Medicaid services, specifically for patients from 21 to 64. However, over the last 10 or 15 years, there's been a recognition that substance use disorder treatment really requires inpatient stay. And for Medicaid to effectively treat persons with SUD, to have access to IMD services is really important. And so 1115 waivers have been used to kind of overcome that IMD exclusion. Another way that 1115s are used is if the federal law prevents a desired population from being covered. So Medicaid is barred from paying for health services for incarcerated individuals, except for inpatient hospitalization in states that have expanded Medicaid. But there's a lot of states that have said, including Washington, that have said, we really want to provide services to these individuals as they approach their release. But Medicaid doesn't allow, the Medicaid rules don't allow that. Can we have a waiver so that we can provide services to individuals, maybe 30 days, maybe up to 90 days pre-release, so that we can ensure that when those folks leave carceral settings, they have care plans and treatment in place, and it's an easier transition. And 1115 waivers have been used for that. There's also certain program administration elements that federal law might prevent that states could look at. So Medicaid doesn't allow premiums except under certain circumstances in CHIP. In some states, when the ACA was being rolled out and states were looking at Medicaid expansion, they said, well, actually, we want to add premiums to our Medicaid program. And so states used 1115 waivers to design premiums and copays for that Medicaid expansion coverage. It's interesting, some of those have been rolled back, some of them have not, as those 1115 waivers come up for renewal. So we can go to the next slide. So 1115 waivers are approved at the discretion of the Secretary of Health and Human Services. And there's a couple of requirements that the Secretary has to meet. First is that they must be budget neutral. So I put this in quotes because it's really important. There's a whole bunch of different ways that waivers are considered. 1115s are budget neutral, which means the cost to the federal government must be the same with or without the waiver. And this is over the 5-year period of the waiver. And that budget neutrality is a place for significant kind of fudging of numbers depending on a state's relationship with the federal government. So the way that you might think about how did somebody fudge the budget? So if I'm looking at a waiver that starts in 2025 and goes for 5 years, I have to start to trend out. So this is what it costs this year, and I have to trend what it's going to cost the following year and the year after that and the year after that in a non-waiver scenario. And those trend rates are often subjective, and a state that is working with the federal government closely might get a very favorable trend rate, and a state that is not, or kind of seeking to operate something that is not something that the federal government wants, may get an unfavorable trend rate. And so that's kind of the way that you can get to budget neutrality, even though it seems like you're spending more money than you would otherwise. The waivers also must promote the objectives of the Medicaid program. And this came into to debate when a number of states sought to use 1115 waivers to add work requirements to Medicaid. And it was litigated that in some cases, not every state kind of fell into this, but in some states that said, we believe that employment promotes health, and promoting health is what the Medicaid program wants to do and is seeking to do, that's why we kind of can approve these waivers. Courts actually said, actually, the objective of the Medicaid program is to provide healthcare services, not to promote health, which is how a number of states lost the ability to include work requirements in Medicaid. It should be noted that because the approvals are at the discretion of the secretary, who is a politically appointed cabinet member, that the approvals really represent the policy of the administration. And that's why you see different types of waivers be approved under different presidential administrations. These waivers also require significant review, and complex 1115 waivers can take multiple years to be negotiated. And often what we're seeing right now is that very complex 1115 waivers, and California is kind of the poster child for this, will often have submit a big waiver and then have pieces of it approved as they kind of get through the review process, because different elements are reviewed by different parts of CMS, of CMCS, and of OMB, the Office of Management and Budget. Before 2021, no 1115 waiver was ever rescinded by an incoming administration. That changed. There were a couple of waivers that were approved in very early January of 2021 that were then rescinded by the Biden administration in February and March of 2021. And so the presumption is that that precedent, sorry, my dog just decided to knock something over. That precedent of maintaining a waiver and saying like, well, you know, it got approved by the last administration, like we're just going to let you deal with it. That might be out the window, and I think it's something that bears watching. Next slide. So what should Washington be thinking about? So first of all, the federal government does not consider contingency when it looks at a waiver. So as the commission thinks about, okay, so let's line everything up, and we can have an 1115 to help with Medicaid, and we can have a 1332 to help on the marketplace side, and we can have a CMMI waiver to help on Medicare and maybe with some delivery system reforms. Each of those are kind of viewed independently of each other. And so if the budget neutrality calculation for an 1115 waiver kind of counts on authorities or savings or flexibilities provided by other waivers, CMCS will not look at that. They will not presume other waivers to be approved. And so that is a challenge when you're negotiating with the feds. Now, sometimes you can find ways to get around that. I would say the 1332 team is way more sticky on this point than the 1115 team, but it is important to know that kind of the feds will not always allow a waiver to say like, oh, so once that's approved, this will flow this way, and so we'll approve you kind of pending that other approval. Other considerations, so program integrity and tracking what you said you were going to do and how you said the money was going to flow, and evaluation of the waiver are very large components. Because 1115 is a demonstration program, you are saying to the federal government, we think this is a novel way to approach providing Medicaid services. So we want to kind of have this flexibility, and the feds will say, okay, we're going to give you that, but you have to prove certain things to us. And sometimes that comes in the way of audit requirements to make sure that enrollees that don't meet eligibility requirements are not kind of enrolled because you've changed or opened up some of those flexible eligibilities, or that if benefits or services are provided through different models or different provider types, that enrollees still have the same access that they would have had to those services without the waiver. And so these robust evaluations and audits are really a big part of the waiver program. Obviously, like different administrations take different tacks. So if a waiver was approved by one administration and the next administration didn't really like it, the evaluation requirements are probably going to be like tuned up a little bit. And if a administration approves a waiver at the beginning of its term, it's likely that the evaluations are going to be less kind of stringent during the course of that administration's term. Next slide. So let's talk a little bit about how 1115 works in the kind of structure of Medicaid, right? So I know that you've talked about Medicaid, but just to give you a kind of brief reminder, Medicaid has mandatory populations that you're required to cover, and mandatory benefits. It has optional populations, and these are populations that you can cover by raising your hand and saying, hey, I want to cover this population. And it's optional benefits, and you can say like, hey, I want to provide these benefits and that are outside of the mandatory list to our to Medicaid enrollees. And when we talk about the kind of mandatory and optional, right, mandatory populations have a set of mandatory benefits, and then you can add on optionals, but you don't have to be equal. You don't have to give everybody all of the optional benefits that you provide. You can pick and choose which benefits go to which mandatory population. And kind of same thing with the optional populations. You can choose the optionals, but generally optional populations also have to get all of the mandatory benefits, right? So you got to get all the mandatory benefits, if you're a mandatory POP or an optional POP, but the optional benefits you can pick and choose. And then we have waiver populations and waiver benefits. And because waivers allow you to pick and choose new populations to serve or new benefits to provide, that's really like you can choose to provide any or all of those mandatory or optional or waiver benefits to a waiver population. And you can also choose to provide any of the waiver benefits to any of the mandatory or optional populations. There's like a lot of picking and choosing when you get down to the bottom of the list, but at the top of the list, it's required. So let's go to the next slide and talk a little bit about how states have thought about expanding their coverage, right? Growing that waiver population bubble at the bottom of the previous slide. So we have seen a number of states expand coverage, but it's almost always a limited population. So here are some examples of limited populations that states have expanded to. So we talked about incarcerated individuals. Prior to the Inflation Reduction Act, or was it ARPA? One of the two big bills from the Biden administration, postpartum kind of was a mandatory 60-day. You had to cover somebody postpartum for 60 days, and states could use a waiver to expand that as they saw fit. Now it's a kind of the postpartum up to 12 months has become an optional population, and so you don't have to use a waiver to do that anymore. But there are some states who still seek to do it through a waiver in order to provide new and interesting benefits to that population. Individuals with SUD, substance use disorder, regardless of income or up to higher income levels, is a population. I've seen this a lot in non-expansion states that haven't expanded Medicaid up to 130% of poverty. They will expand out for individuals with SUD to ensure that those folks have coverage, even if they don't have access to kind of comprehensive coverage. Oregon is my individuals up to 200% of the federal poverty level. This is what is commonly referred to as Oregon's Bridge Plan, as they are going from the Medicaid continuous coverage requirement under the COVID public health emergency. And they are going to transition these folks into the basic health program option of the ACA, but they couldn't line it all up in time. And so right now they have a waiver to expand Medicaid up to individuals up to 200% of the federal poverty level. And they used a waiver for this so that they could say this population has access to Medicaid until the basic health program is up and running, and then they will flow into to that program. Caregivers of children is a place where we've seen some expansions of coverage. So if you are a non-parent caregiver of a child with special health care needs, you might be somebody who is receiving Medicaid coverage. And then seniors with mental health needs, if you're over the income limit, then you might be able to get certain coverages through Medicaid because of mental health needs. So a couple of things that I want to highlight. In the District of Columbia, the District of Columbia has the high, and I should say DC is treated just like a state for Medicaid. It's like Medicaid considers themselves to have 51 states and then the territories. DC has covers adults up to 215% of the federal poverty level. And this expansion was done as a state plan amendment. So I think it's really, and on the next slide, I'll talk about kind of the different thoughts there, but this was not a waiver. This was done through a SPA. And so this has become an optional population. And really, anybody is an optional population, but if they fall into that optional population, then you have to provide those mandatory benefits and then a certain level of optional benefits. New Mexico recently inquired about an expansion up to 400% of the federal poverty level. New Mexico is currently reviewing potential legislation to allow anyone in the state to buy into their Medicaid program with the goal of saying up to 400% of poverty, let's make them real Medicaid, like matchable Medicaid population. And CMS said that that would be allowable through a waiver. Obviously, kind of that's a very like broad, yes, we think you can do it, and we're going to have to see the details, but there was nothing, CMS did not say like, no, here are the barriers to that being a waiver for you to consider. But no state has done a really broad-based expansion of coverage up to a FPL limit to be determined through an 1115 waiver. We can go to the next slide. So why do we think about the SPO? David, I'll pause and you can ask your question.
Yeah, thanks, Dan. I'm thinking about the example you just gave us and trying to picture how New Mexico would prove that they save CMS money when they're expanding the population so dramatically, or if this ultimately were approved. Is that obvious to you how Mexico would demonstrate that?
So I would say there's a couple of elements there. So first, it's really important to note that New Mexico has the highest percentage of their population on Medicaid of all of the states. They just happen to be a very poor state that has a very kind of generous Medicaid program, and so they've somewhere in the range of 48 to 52% of their population on Medicaid, and they have a very small commercial market. And so the idea here is like the actual numbers of people that would be transitioning to Medicaid are relatively small. We would account for for folks above a certain income threshold, I think they're thinking around 250% with some premiums. So that starts to reduce the cost of the federal government. And by kind of getting more folks and kind of having everybody have access to the Medicaid program, we would be able to sharply reduce the amount that we pay on disproportionate share payments to hospitals for uninsured. So the goal is, if we really push the uninsured number down, then we're not going to have to reimburse out of the Medicaid budget to hospitals, and that's the savings. I would say they are still working on the math.
Got it.
And that's kind of their general idea, but that's the kind of pathway.
Okay, thank you.
Yeah. So on the next slide, thinking about, as I mentioned, DC expanded through a SPA versus a waiver, and like, why is that different and what's important to think about? So if you expand coverage through a SPA, that is going to allow you to say, here's our new population, and you're going to get your match for that population. It's going to be kind of your standard match rate. It won't be your expansion population match, like the 90%. It'll be whatever your kind of general population match rate is for that population moving forward. But it's definitely going to require you to find the state dollars to cover that population. Also, that SPA is going to require the mandatory benefits to be provided. And then the way that Medicaid works is it has like these groups of populations. And so if you're going to say, well, I'm going to expand, say, group 6 or group 7, there are certain optional benefits that you say, I provide these optional benefits to group 6 and group 7. So you're going to have to provide those optional benefits to your expansion if you do it through a SPA. You can't pick and choose the way you could with a waiver population. Now, why do we think about a waiver? So if you expand through a waiver, you could start to pull in some of those other spending kind of current state dollars as DSHPs. These are designated state health programs that the federal government may or may not, which is kind of during the course of negotiation, consider to be the state matches. This is the nursing school example that I provided earlier. But overall, the FFP needs to stay neutral on trend. And then different benefit packages could be designed for your expanded populations. And you could actually say, like, so we're expanding, to adults 21 to 64, and this is what what they get. This is what our 65 and olders get. This is what our kids get. And so you can really kind of define, and you could include those premiums and copays. If you do a SPA expansion up to 400, you can't include premiums or copays for folks over that income level. So a couple of questions, I think this might be my last slide, but a couple of questions that I know have come up that I want to make sure that we get to as we're thinking about this. So I know there's been a question about asset tests in classic Medicaid. So generally there's like 2 ways an asset test plays into Medicaid eligibility. The first is states can say, we have an asset test, and Medicaid is going to determine what your assets are. The second is Medicaid says, well, we will accept you into Medicaid if you are SSI eligible, and SSI has an asset test. So Medicaid can't get around SSI's asset test, but Medicaid can say, actually, we don't want to have an asset test anymore. Arizona has eliminated their asset test. And California is in the process of eliminating their asset test. Arizona did it through a SPA, so they just said, we're getting rid of it. This is how we're doing our eligibility now. California is doing it through a waiver, so that they can identify we're using some of the dollar changes as part of our budget. So that's just kind of, there are different ways to do it. You don't have to use the waiver. I see Roger has a question. I'm happy to pause and dig in.
Oh, my apologies. I'll ask at the end. I'm having trouble with my system here. Excuse me.
No worries. And then I know that there were questions about, like, well, are there things that we can do in, say, the expansion population or in a chip eligible population that we cannot do in for, say, classic Medicaid, right? As far as benefits or services. And I think the answer there is generally yes, right? And this gets to that question of the different mandatory populations do have different requirements. So a good example of that is kids have to have certain benefits provided. If you were to expand in a population and through a SPA, you would have to ensure those were provided. If you were to say, like, we want to like totally change everything and like operate everything under a waiver, the federal government will still say, that's great, but your kids still have to have access to EPSDT. There are still those kind of bright lines that CMCS has said, like, you can't pull that benefit away. There are some benefits from kind of a more classic Medicaid perspective that have been able to be stripped away. Different administrations are going to be more or less okay with that. But I would say that there is differences in what can be provided. And I'm just kind of running through the list of questions just to make sure, I know that there are, so I would say one element that's important to remember is that adding folks to Medicaid through a waiver or through a SPA still creates an entitlement opportunity for those enrollees. Now, in a waiver, you can negotiate with the federal government and say, like, we only have, this amount of space in our budget, and so we can't actually like create an entitlement to say like everybody up to 250 is able to enroll in Medicaid, and that's part of the negotiation. And they might say, okay, so then how would you create a cap, and what would, how would you kind of allow that to be like first come, first served, and how would you deal with renewals? And so a lot of those questions are going to come into play. From a waiver perspective, from a SPA perspective, you are creating an entitlement. And so it's important to understand that. And as you think about, like, if you were to think to bring everybody under a single waiver umbrella, there are going to be requirements included, like that program audit requirement that's going to say, like, well, here are our eligibility rules. Are you following all of those eligibility rules for folks who are enrolling, even if they're enrolling in a waiver-based program? Because you still have to check all those boxes in order to qualify for your federal funds. So I think I'll stop there because I've given you probably a ton to think about, and I'm happy to go through questions.
Eddie?
I have a question. So with the waiver and the SPA, is your research across all the states, is there a difference in duration across administration?
So generally, when there is an expansion via SPA from a population perspective, it is like relatively permanent. And then there are kind of only big challenges that would cause clawbacks on that expansion, right? So we haven't seen DC clawback. Prior to the ACA, states covered parents of eligible children at different levels of FPL, and that is also an optional population. And when the ACA came about, like, everybody reverted to, we're going to go to 138 and allow those parents to use the marketplace coverage, except for DC. And so it's really like those big kind of overarching changes. You will see some clawback in optional populations, which is kind of the SPA population, in significant budget challenge years. So if like there's really no money and you're talking about like 5 or 6% of your state budget needing to be cut, then that's probably a place where you're going to start to trim some of those optional populations. The waiver populations, Right, so waivers operate under 5-year operational kind of guidelines, and then they can be renewed, and then every 5 years you're gonna like renew it, or you're gonna like renew with changes. Usually, almost every time you renew with changes. And so you'll see some like nipping and tucking around the edges of those populations if they see like, oh, well, this one's working well, but this one's not. But again, all of those waiver populations tend to be like very specific targeted population. And so they will only like nip and tuck if number one, they're running out of money, or number two, there's kind of a finding that like actually it doesn't help us to provide these services in certain ways. An example of that might be there are a number of states who expanded the postpartum coverage, but only to postpartum persons with mental health needs or substance use disorder. One state did that. It was like, actually, it turns out we're not serving any like we are disproportionately serving white postpartum people, and we don't like that, and so we're going to pull back on that because we had an unexpected outcome from our waiver.
Okay, thank you. And then one follow-on one. Between the waiver and the SPA, the FMAP that you spoke about, each one will receive the state's match, 50. And the difference would be that on the SPA, the state's going to be required to do what differently to get that FMAP?
Right. So in a SPA, generally the state's going to have to use its current matching tools, the current ways that it allocates dollars to qualify for the state match, and just expand that from a numerical perspective. In the waiver population, what you're going to be able to do is say, all right, because this waiver is covering more people, almost always we're going to cover more people, but we're going to do this and that and this a little more spartly so that we're spending less on certain populations, or like I said, like we're spending less on uninsured care and disproportionate share payments. And so we are going to allocate those savings and find other match through our DSHBs. And, you know, to be honest, a lot of these kind of waiver budgets are very much like theoretical. And like, so here's what we think we would spend if we did this, and here's what we think we would spend if we did that, and here's what we think our trend rate is going to be. And I think we're close enough to budget neutral. What do you think? And that's kind of a big part of the negotiation with the federal government.
Okay, because I just had this feeling that it seemed like the waiver was, because of the cost neutrality, was protecting the state a little bit more in the SPA.
So I would suggest that from a general revenue perspective, a waiver implementation of an expansion advantages a state's general revenue than from the kind of as opposed to a SPA. Now the feds also like are going to have protection in the waiver because they get to like push on that budget neutrality, right? And so feds are always thinking about because Medicaid is an entitlement, I need to understand what my expected expenses are going to be. How much match am I going to have to pay out? And SPA doesn't protect the federal government. Waiver does. But I also think that like waiver opens up opportunities for states to find different ways to find match dollars.
Thank you.
I think David has a question.
Dan, thanks for this presentation. I thought it was great. I think, you know, we're going through this exercise of talking about how would we achieve universal coverage through a unified system, you know, talking through Medicare and commercial, ERISA and Medicaid. And so I'm trying to apply what you've described here to this exercise we're going through. So would you mind opining for a minute on how you think we would use this information, or Oregon or California who are doing similar things, what we might specifically do to achieve a unified or work toward a unified system with this?
Right. So I think it's important to think about waivers, and I say this kind of on all waiver models. Waivers are tools to achieve policy goals. Obtaining a waiver is not the policy goal. It shouldn't be. But rather say, like, how can we structure this waiver so that we can create a unified system? So one way to say that is you say to the federal government, so we're going to take our entire Medicaid population, and we are going to provide them the same or better level of services at the same or better cost to the enrollee as what they receive in Medicaid through this UHC structure. Here is why it still counts for match, right? Because that's basically what the feds are going to say is like, Medicaid isn't a separate system. It's just saying like, yes, we're checking all of these boxes so you can operate and provide health services in the system of care that you have in your state that meets all of our requirements, and then we'll pay, our half when you prove that to us. And so as long as that kind of, you're able to prove through the waiver negotiation that a unified system meets the requirements, or you say, we don't think we have to meet this requirement, and here's why, and that's why we're requesting this kind of demonstration project to prove that we don't have to provide that, then that's kind of how the state would get to where you would kind of want or need to be. A really good example of that is this kind of like that Medicaid doesn't always operate on its own. Is in New York and Minnesota, they have their basic health programs. And those basic health programs like literally operate exactly the same as Medicaid. New York especially, it's exactly the same. The managed care organizations are the same. The benefits are the same, but they just get different funding streams to pay for the enrollees. And you just have to, like on the back end, the administrative side is the state saying like, Dan Muse is an enrollee in BHP, and David is an enrollee in Medicaid. And so I'm going to get this much money from this federal pot for Dan and this much money from this federal pot for David, because I've checked all of the boxes and proven to you that I deserve to get that money. And I think it would be generally the same under a unified construct. It would just be like kind of everybody, and that's a lot of administration and a lot of work, well, more than what the state is currently doing, but probably less when we think about it from how everybody operates in the state.
Hey, Dan, could I try a cut at that also, just real quick?
Yeah.
Okay, as I would think about it, and I'm trying to answer David's question, one to be able to say, we have the Medicaid program and we want to bring it into a new delivery system, let's say a consolidated delivery system. But it's bringing in the existing Medicaid program, if you will. And 1115 waivers will allow for that pathway to try to bring the consistencies and compliance. A lot of detail on that. The other flip on this is what states do. And this is where saying, well, in addition to that, we want to expand our population and try to draw a federal match for it. And that's a different cut at it, if you will. And to that degree, you really do have many challenges in trying to deal with budget neutrality. I mean, I've been through this process before. It's not that it can't be done, but I'm going to use the example of New Mexico. I just want to say good luck in trying to do that. But the point, what they're trying to do is to say, no, we want to bring in another group of folks that we can draw a federal match for under the Medicaid program. And an example being is our state has already to degree an expansion of coverage, state subsidies and premium subsidies unique to folks who are in the Affordable Care Act in our exchange. And the argument might be is, well, can we can, rather than having this state dollars pay for that, can we kind of convert all that into new populations that Medicaid could fund?
Right.
And I was on theory you can, but as Dan would point out, you're gonna have to demonstrate budget neutrality for that. And states can get themselves into problems if they don't think that through carefully. I always think of Tennessee. Dan, you may remember the fiasco that had. So,
Yeah.
that makes
So,
sense to you at all?
It makes sense to me. I follow your logic there. And I think, like, you know, a great example is, so Massachusetts actually uses Medicaid dollars to pay for its subsidies in the marketplace, the ACA marketplace. And basically this was that waiver came from kind of a historical 1115 that they were able to just like work forward and finally kind of like turn, when the ACA happened, turn into their Commonwealth care program. And actually it was the Massachusetts Health Reform where they were able to flip that over. You know, I would say there's a couple of things to be thoughtful of. There is new budget neutrality guidance that is kind of coming out of the feds. It was going to be really restrictive. I think this administration loosened it a little bit, but not completely. And so every state, right? If you you know, go to your neighbors to the south and ask them how much banked savings they have in their Medicaid waiver, they're going to talk about multiple billions of dollars that they can kind of say like, oh, well, we're still budget neutral because of the savings that we've had for the last 20 years. That's probably not going to be able to be carried forward moving forward as this guidance gets implemented. And so it is something that's important to consider.
Okay. I think okay. One more question, Christine.
Yeah, so just to clarify, so does doing a state plan amendment get you out of the requirement for budget neutrality? And if so, why wouldn't New Mexico do it that way?
Yeah, it does. And the reason that New Mexico wouldn't do it that way is because they don't have the general revenue space to find the state match. And so they would need to use the waiver to kind of amend other parts of the program to be able to find that state match.
Thank you.
But Dan, one of the example B is we got a lot of money in disproportionate share payments. We're not going to do those anymore. We're going to take those federal dollars and GFS and do it on an expansion. They'll take the burden off of hospitals. That's
the argument that would generally be made. Yeah.
Yeah.
Sorry.
Yeah. It's just, this is, I know we want to keep going with Dan because this is, and it's almost, the questions just keep raising more questions. But I think I'm concerned about moving on because of our timeline. Dan, this is terrific presentation. Really appreciate it. And really thank you for your time, and hope we still have your number and your email. Because we're going to have more questions as time goes on.
Definitely. Please feel free to use me as a resource. Thank you so much.
Thank you. Thank you. I'm going to turn to our own state now. Washington's had a really long and successful history of using waivers to innovate in Medicaid. And it'll be important to understand what we, kind of what's our history and what we've done in the past. I'd like to welcome Michelle Needham, who will share Washington's experience with 1115 demonstration waivers and the waiver development process. Michelle's the Chief Policy Officer for the Healthcare Authority, and her presentation is under tab 6, and I'm delighted to welcome Michelle Needham.
I can't hear.
I have to turn off mute first, don't I? So thank you.
Yeah, you do.
That makes it easier. I just want to say that was really nice to listen to Dan's presentation, and then a nice overview of 1115 waivers and 1915 waivers from a broad perspective. That was really helpful. And I'm cognizant that I have other experts in the audience, so I know that they will contribute to this conversation, Roger and others. So I was asked to come and do a brief overview of our recent experience with 1115 waivers at the Healthcare Authority. And I know Roger's already done an overview of some of that. at a previous meeting, so you know a little bit about our current waiver. I plan to just talk a little bit about the requirements, more process stuff from the state side. So the development of the process and the legislative role in that, some of the timelines and implementation process, because it is a pretty meaty process. So Dan already provided an overview about what an 1115 waiver is, so we don't need to spend time on this. It is a demonstration, as he said, of some unique ideas. And then the states get sort of that demonstration opportunity to show a unique idea or different population or benefit ideas. And we start with that through a draft concept paper that we submit to CMS, outlining the concept. They give us some feedback. Sometimes they said, no, this is absolutely no go. Don't even try. Other times they're really helpful in saying, well, you know, if you approach it from this different angle, you might bring it back and think about it with us. So oftentimes we are getting legislative directives to apply for waivers in a certain way. And that has some pros and cons to it. Certainly the authorization is helpful, but often they're too prescriptive. And then when we apply or work with CMS, they're no-goes because they just don't meet the criteria that CMS has in mind. So then we, after we've had that back and forth on the concept, then we begin drafting the actual application. As Roger knows, those are really big, comprehensive packages that require a lot of data and background evidence. It can't just be, I've got this great idea and I think you'll love it. We need actual evidence to submit to support the idea. Either it's been tried somewhere else. We've got a lot of research and empirical studies to submit in our documentation. And then as Dan noted, we're having some discussions around the funding. We have to do a whole projection around that enrollment and projection around the expenditures to, again, hit that federal budget neutrality expectation and sort of fit within a box to try and make the package work for CMS. So that's the data collection point. Next slide, please. After we've done all of that work, and we'll talk about the timeline for how long that took in a moment. Then it goes through a completeness review from CMS. They review the whole package and confirm that it meets their requirements. If it does not, then we have to go back and complete all of those missing elements. It also goes through several formal public comment processes and public forums, formal tribal consultation, and some other transparency requirements. So a lot of checking the boxes, if you will, and making sure that it's very public. Again, there's additional tribal consultation that is a continual process. So we will just note that that's an additional timeline and process administratively. Next slide. And the public comment and transparency, I think I already noted that we have to go through that process. There are several different postings, both federal public comment and state public comment periods. So those are filed publicly with all the documents. And then we have public meetings or webinars to gather feedback on those documents as well. And then after all of that, we begin the negotiation process with CMS. And I'll tell you that the last negotiation we just did was several years. So it is not a quick and easy process. And I think the timeline is coming up. I'm hoping I have that next. Next slide. Yes, here we go. So again, we talked about, these are some of just the visual of some of those steps that we just talked about, more processy, but to think through all those different stages. Everything has very formalized process stages and timing. It's a very formal process from the CMS side. And as noted at the end, the negotiation can be very short, 3 months to 2 years. I have found them to be longer negotiations for all of our big and more complex waivers. During the COVID period, we did have some emergency 1115 waivers, and they did help move those very quickly just to ensure we could maintain coverage during COVID. So this is just a high level overview then of our actual experience. You got the process description in the formal description, and then this is our experience in the last waiver that was recently approved in July or June 30th. We started on July 1. So we developed that initial concept paper that I talked about in 2020, in the summer of 2020, and submitted that to CMS. Started those conversations back and forth with CMS. We submitted a formal application in July of 22 after 2 years of conversations. And then we had, again, formal negotiation on that application with all of the documentation and budget neutrality pieces, formal negotiation up through June 30th of 2023. And I do mean through June 30th. We completed that day. The waiver is authorized for 5 years. And the previous waiver, we also had, there are many waivers, but these are the big comprehensive 1115s that we've had that we're calling our Medicaid Transformation Project. The previous Medicaid Transformation Project was also a 5-year demonstration, but we did extend it. So that started in January 2017 and ran through December of 21. We did have a 1-year extension related to COVID. And then CMS extended another 6 months while they continued the negotiation. They were not yet ready to approve our waiver because they have so many waivers in the pipeline and they needed to stagger and extend ours to allow more time. So we did finally get that approval, but that means we've started the clock running on all of the next formal documents that are required to even begin designing what we will implement in most cases. Although the waiver had many components that were part of the first waiver, and we're continuing those, as Dan noted, states do renew the most programs and then tweak them and or add on. And so we did renew many of the programs in that first 5-year demonstration and have added on and modified a number of things. And so those new programs are really in a design phase in particular that need protocol documents, which are detailed documents that CMS has to approve, just outlining what the benefits are and the participation requirements, for example, and then the detailed implementation plans and some detailed evaluation design. Dan also described the requirement for a external evaluation that's quite extensive. And for example, the first waiver, we had a $5 million evaluation project with the Oregon Health Sciences University. They're still completing that because they want to make sure they get all of the data from the first 5-year experience, which is really a 7-year experience now. But so it is a pretty extensive evaluation process and it does take time. The other parts, of course, after we get CMS approval, we are now in the phase of needing our spending authorization. We did get some of that last legislative session in the budget because we had applied for the waiver already in that July 22 period. So we submitted our budget packages reflecting what we had submitted. And that was put in last year's budget, biennial budget package from the legislature. In the meantime, we then continued negotiations with CMS on a couple of significant changes that need to have spending authority in this budget cycle. So for example, we have a new reentry program for those individuals coming out of prisons and jails, and none of that was in last year's budget package. So, and some fine tuning, of course, for things that we know differently this year than we did last year. So we do expect that program implementation to actually take several years. We're again in design mode for those new programs. Just using reentry services as an example, we anticipate at the very earliest that we'll be able to actually put in services or begin paying for services in jails and prisons in July of 25 at the very earliest. So, and that is a sprint to get there and develop the capacity and infrastructure to allow those services to be delivered. And then there are, of course, all these other reports, hundreds of deliverables to CMS attached to a waiver, quarterly reports, annual reports, quarterly evaluation reports, a lot of external and all the budget monitoring and budget neutrality monitoring. So I would say that the package that comes with the waiver is very administratively heavy, and it's not the most efficient way compared to a SPA to manage expanding services, because there comes all this extra reporting and monitoring that is slightly different from our other infrastructure. See, I don't remember what's next. Oh, some comments on how we sustain the waiver. So as noted, it's a 5-year demonstration initially approved. We then go through the renewal process to sustain those waiver programs that we think are worthy of sustaining, or have support and interest. We did sustain most of the programs in the first waiver, and then added and modified to some of them. And I'll just use one as an example. So we have a program in the waiver that's foundational community services that provides housing supports and employment supports for a certain targeted population with behavioral health needs, for example. And we were able to expand that program with a slight modification to include teenagers down to 16. So we'll be able to slightly grow those programs to help more people. And in general, you must, the statute or the regulatory requirements, I guess, are that we apply for a renewal 12 months prior to the end date of the waiver. So a year before, you need to be starting your renewal concepts, 2 years in advance then of your end, if you're submitting your concept paper and thinking through that cycle. So it is a really active, ongoing cycle of thinking about the waiver and what's next and how do you sustain it and how do you apply it and how do you do that budget neutrality. So it's I think too short of a cycle in some ways to really demonstrate all of those new concepts and the budget neutrality while you're backing up into the 3-year timeline to renew it and think through it again and show that you've succeeded. So many states, though, and Roger can probably speak to this better than I think, have sustained their waivers for upwards of 20 years. So some, they really have a long lifespan once they get going, if they're programs that people do appreciate and want to sustain. Some of them we would hope to graduate to a SPA so that we get out of that cycle of administrative add-ons, if you will, and put it into the regular program. And I think Dan used one example with the postpartum coverage to 12 months, that we had that in a waiver. That now for the core program is in the SPA, so it's in the core program of Medicaid. We do have another component in our waiver to also extend postpartum coverage for an additional population. So there are always add-ons that we continue, but that one has graduated into the SPA as an example. And then we start the process over again. So it seems like an endless cycle to some degree, but again, hoping that we can graduate a lot of those into a SPA at some point. The other ones I would pull out as an example that I would be hopeful. I don't know, I see the path immediately, but the coverage for and financing for services, behavioral health, mental health services, SUD services in a IMD. Those are both in our waiver to allow us to do those. But someday we would like those to be in a SPA because they should be part of the main Medicaid program, ideally, that you would not need to have additional overlay of reporting and evaluation for something that should just be, frankly, a Medicaid service, in my personal opinion. So this is just a sample. I know it's too small to read and you wouldn't want to read it anyway, but of some of those additional deliverables and reporting requirements that come with a waiver. I think I noted some of them before with the multiple protocol documents and or detailed development documents, so that although the program conceptually has been approved, it's like we've got the authorization to build a house, and a general blueprint, and now we're submitting all the next level detailed blueprints. Like, this is what color I want the bathroom to be, and I really would like it to have some electricity, and I would like to have some tile. So those are the protocol documents, and then the implementation plan would come after that to describe all the ways that you actually plan to implement and all the partners that are participating in those activities. So that's just a sample, not to belabor the extra requirements that come with a waiver too. I think one of the questions earlier, wouldn't we want to think about this for the Universal Commission, and how do we apply this to that lens? Don't be thinking about this end at this point, I guess. But I think that was my overview of the process, and I assume that you might have some questions or some discussion around waivers in general and what we've experienced within the Healthcare Authority.
Looks like Eddie has a question.
I do. Yeah, so when Dan was speaking to the favorable trend that you would receive from CMS for your waiver when you propose it, and then you're talking about all of the documents you have to submit to support the neutrality. Can you speak to that?
Sure. A couple different pieces. For example, the documents we had to prepare to demonstrate our proposal to cover children with extended eligibility from 0 to age 6. So we had to compile a lot of documentation to demonstrate why we thought that would save money and why it would be appropriate and within consistent with Medicaid goals to really ensure that those children stay covered for 6 years. So that was the concept phase, documentation. And then you go through the projections of which children will be covered, for example, over that 6-year period of time. What's the additional cost to keep them enrolled versus the churn and the additional cost for them coming in and out and losing access to services. So that's one piece. And then the budget neutrality demonstration has a lot of esoteric budgeting descriptions. Part of it is identifying savings that we had from the first waiver, unspent potential that they had already approved that we could carry forward. We had a little bit, but because we only had 5 years, we didn't have very much savings. Like Dan made a reference to some states that have billions of dollars. That was not our experience because we'd only had 5 years and less than that by our first application. So carrying forward some of the dollars we had left, the unspent from the first waiver, projecting what those new programs would look like with the new populations, the new program services over 5 years. You do a with waiver version and a without waiver version. So what would federal Medicaid costs look like with the waiver, with all of our new bells and whistles? And what would it look like in our scenario without the waiver? And I know Dan implied that you could negotiate a inflation rate assumption. That is not true. That's not been our experience in this go around. That they have a new president's definition of inflation, and that was the number that we had to use. And that was fine. You just model these scenarios, and they're all models. They're not real life scenarios. Nobody can say exactly what the inflation will be over 5 years, of course. And in our last waiver, we in fact went back and negotiated some changes to the budget neutrality because our first waiver included and still does a program expansion for long-term care services and supports with additional targeted services. And since that time, we've gone back and had that program pulled out of the budget neutrality calculation. It is still in the budget, it's in the waiver in every way, but it's not in the budget neutrality calculation. So because it has really different inflationary factors in long-term care, and we cannot control those in the same way that we might control other Medicaid medical expenses. And the legislature in our state, for example, increased the minimum wage and some other bargaining agreements for long-term care services workers. And that really drove up the costs that we were seeing in that portion of our Medicaid waiver in the first round. So we, again, went back and negotiated over a 2-year period to pull that out of the budget neutrality calculation. So it's not a really straightforward process, the budget neutrality. It is an extended negotiation about, well, what will be counted in? What's a pass-through dollar? What just is part of the waiver but won't count towards neutrality? So I don't think that there's a really good playbook on that. Maybe other people who've lived it longer than me will think that there's a really clear playbook, but it seems like it's very confusing and you have to really negotiate every line for extended conversations on what counts and what doesn't count. But Roger might have observations about that differently than me.
No, that was good. Thanks.
He says no. We are at time, Roger. Can it wait to another part of the agenda? Okay. Don't lose it. All right. I think this is actually our 5-minute break. And Michelle, I want to thank you for taking the time with us today. I also want to note that we know Michelle's number. So we'll have other opportunities to connect with her as we move forward, because obviously we're in very preliminary stages.
Yeah, thank you all. Thank you all for being on this work group as well. We really appreciate it. So.
And now we have 5 minutes, take 5. So at 3:38, we will start back up again.
Marty, we can go ahead and advance to Dr. Spivak's presentation. Thank you so much. Perfect. Thank you so much. Hi, Dr. Spivak. We're going to give folks just a couple more minutes until we see some cameras come on. If folks are making their way back to their desktops, laptops, members, please feel free to go ahead and turn on your cameras when you come back.
Can you hear me okay? Audio's fine?
Yeah, you sound great.
Great.
Angela, can you hear me?
I can.
Yes.
I'm sorry. Is there something I should do to get myself back on video?
Let me see if I can.
Sorry to be.
Let's see. Have you been prompted to start your video, Roger?
Well, try again. Here it is. Here.
Yes, there you are. Perfect.
Hey, Mark. Sorry, I have transmission problems today here. Thank you.
Okay.
Hey, Roger.
Go ahead, Pam.
I was going to say, Roger, I thought you had a question there at the end of the last presentation, so I felt like I was moving things a little bit too much. So I hope we can get back to it, whatever it is.
It's a very arcane one we can talk about later.
Okay, good.
All right.
How are we doing, Angela? Does it look like people are here?
Yeah, I think we've got everybody. I think David left his camera off when just before the breaks too, so he might not be able to come to camera right now. But I think we can go ahead and get started.
Yeah, I'm back, Angela. I'll just be off camera for a minute.
Great, thank you so much, David.
Okay, all right. Thanks to Michelle in that great presentation. Our last topic is focused on the Commission's question to FTAC about barriers to access for Medicaid patients. This is a really important issue for us to think about. The Commission noted that Medicaid patients face barriers to access, which is often cited as being attributable to lower provider rates. And FTAC and the Commission have both discussed independent physicians, smaller practices that are more impacted by lower rates versus providers who are associated with hospitals and health systems. So I'm really happy to welcome Dr. Steven Spivak today, who's going to provide an overview of his study that he did during his time at Yale. And this investigates why providers don't participate in Medicaid and identifies some possible interventions. The study and the presentation are under tab 7. And so welcome, Dr. Spivak. Thank you for being with us today.
Thank you so much. And I really appreciate the opportunity to present in front of the committee on what I think is a critical topic. Just for a little bit more background, this work was done while I was at the School of Medicine at Yale University. Was there for a while as a researcher, but recently transitioned to the Lewin Group, which is a part of Optum and United Health's larger conglomerate. I just want to make clear that this doesn't represent the official position of that organization, and is, representative of my time while I was at Yale. And currently, just for a little more background, my position now is Director of Data Quality Measurement and Data Analytics at Lewin. And one of the contracts that I supervise and lead is in the Medicaid space, developing quality measures for home and community-based services and long-term services and supports. And so I'm still working actively within that space. And I also want to, before we begin, just acknowledge the contributions of my co-authors and the funding source for this work. And next slide. So some background on what motivated us to look at this topic. Prior to writing this paper, there had been a number of articles that had come out that had demonstrated, the large percentage of physicians, up to a third in some papers, that were not accepting Medicaid patients. A lot of this work had been done prior to, the ACA or at the early stages of the ACA and Medicaid expansion. But many of those patterns were still holding true into, more current and recent years. Pam, as you mentioned, one of the major reasons that was cited among providers and physicians in terms of their, inability or unwillingness to accept new Medicaid patients were lower reimbursement rates. But that was not the only reason. Much of it was also assigned to administrative and billing requirements they viewed as burdensome. We had been aware of this research, but we're interested in looking at a higher level, which was, as opposed to the individual physician level, we wanted to look at the practice level, because there are decisions that are made there that are independent of individual physicians and wanted to understand kind of A, what may be driving the reasons to not accept Medicaid patients at the practice level, and B, what were the characteristics of those practices. And so next slide. That helped to motivate our research objective for this work was to look at the proportion of primary care practices in particular who had no Medicaid revenue and how they compare to practices that had different amounts of Medicaid revenue across not just the organizational characteristics of those practices, but also some of their population health capabilities as groups. A little background on the data and sample that we used. So there was a large survey that was done in 2017 to 2018 called the National Survey of Healthcare Organizations and Systems. It was a multi organization facility housed at both Berkeley, Harvard, UNC, and Dartmouth. And it was a really neat survey because they looked at various levels within the healthcare system. One arm of the survey was looking at primary care practices, which is what we used. Another arm looked at hospitals, and then a third arm looked at health systems. And the way that we were able to generate our survey frame to get our sample was to use IQVIA as one key database. Traditionally, it's been more of a commercial database, but you're seeing it used more and more in research. And we were able to look at all medical practices within that database that had 3 or more physicians that practice in an adult primary care specialty. And we defined practices as, a set of clinicians that delivered care at a single location in a group practice, a single physical address or zip. Our final sample, we had 1,731 practices for a response rate of close to 50%. We were very excited by that response rate. Historically, that feels a little low, but in the current atmosphere that we operate in, getting about 1 out of 2 practices to respond to a survey was very exciting for us. Not all journals agreed, but thankfully Health Affairs was okay with it. Next slide. We then wanted to define a couple of variables in order to examine our question of interest. The first is we wanted to look at Medicaid revenue a couple different ways. And we did this, we thought about this. There's not a set definition that you can use. We thought about looking at it continuously, just going from 0 to 100%. We thought about different categories. At the end of the day, we settled on these 3 that you see here. And so we grouped primary care practices into those that had 0 Medicaid revenue, greater than 0 to 10% Medicaid revenue, or greater than 10% Medicaid revenue. And then, as I mentioned, one of the goals we wanted to examine and understand better was the capabilities of those practices that fall within these 3 buckets. So the survey was rather long, about 64 questions, and had a number of questions on these different topics that we were able to group together to create a composite measure. So we looked at what care processes were in place for complex patients, if they participated in payment reform programs, if they had registries that they used across different clinical conditions, if they screened for social factors like homelessness or Medicaid eligibility, if they had initiatives to increase patient engagement and activation, and then a couple of different health information exchange and technology capabilities. Next slide. In order to analyze these issues, we did used a couple of different methods. The first was just very basic descriptive statistics. We wanted to compare the 3 revenue category types and the practices that fall within those categories on different characteristics in which, I'll present later in the presentation, you'll see the results. We then, when we looked at those 7 composite scores, had to standardize them because they were based off of different survey questions that didn't all use the same scale. Some were binary, yes, no. Some were Likert scale, somewhat likely, very likely, unlikely. And some were more continuous using a 0 to 10 scale response. And so to account for that and have a more apples to apples comparison across these measures, we standardized them to have scores ranging from 0 to 1 on a continuous scale, with 0 being a total lack of that capability or ability and 1 complete presence within that practice. And then we compared mean scores across those revenue categories, those 3 categories that I defined in the last slide. And then finally, to understand, the way that the types of capabilities and how they were associated with the different revenue categories, we use a generalized ordered logistic regression model to predict the probability of practices falling within each of these 3 groups. And we controlled for a number of variables, including ownership, FQHC status, Medicaid expansion state, patient income poverty levels, where they practice, et cetera. Next slide. So now to get into the results. The first table here, again, these are purely descriptive, not adjusted for any factors. And so you see within the 3 buckets, there are 288 practices out of the 1,700 or so that had no Medicaid revenue in the period we were looking at. 655 had Medicaid revenue ranging from above 0 to 10%. And the plurality, or 788, had more than 10% of their total revenue coming from Medicaid. The story that we'll see in this table is kind of a similar story and not a shocker, I don't think, to most that are familiar with this space. Health systems or hospitals, they're more likely to see Medicaid patients or have greater Medicaid revenue, more appropriately said. Larger physician groups, and especially independent physician practices, start to see less and less of their revenue come from Medicaid patients and are more likely to fall in that category of not having any Medicaid revenue at all. If you look at the total number of primary care physicians within a practice, again, kind of it aligns with the size and ownership type. Largely, there's a lot of collinearity there, but as you employ more and more PCPs, we start to see more likelihood that you are, have greater Medicaid revenue, or it's a greater proportion of your total revenue. That aligns also with the proportion of your clinicians who are PCPs. These smaller practices generally are more staffed by PCPs or greater proportions of PCPs, and therefore more likely when you have a higher proportion of that you're not having any Medicaid revenue or fewer or less Medicaid revenue. Medicaid expansion state, those operating in Medicaid expansion state were more likely to take on or have Medicaid revenue. Also, patients, practices that operated or lived in zip codes where you had more patients or individuals that resided in poverty were more likely to have Medicaid revenue. And, rural or micropolitan practices were more likely to have Medicaid revenue than their metropolitan counterparts. So it's a similar story that I think we've seen before in the literature, but just confirmed with our data that this was in fact the same pattern we were seeing. Next slide. So on this plot here, and sorry, the legend got a little bit wonky with some of the PDF formatting, but in the paper that's in the appendix, it's cleaner. But we've got 3 different categories, right? The blue dots are practices with no Medicaid revenue. The orange dots are practices that have greater than 0 to 10% Medicaid revenue, and the green dots are those that have greater than 10% revenue. And here we're looking at predicted probabilities of whether or not you have a certain capability here on the left on the y-axis, and what category you're falling into in terms of Medicaid revenue. And the dot is kind of the point estimate of that probability, and the whiskers are the confidence intervals. And so we see statistically significant differences when those don't overlap between groups. So for example, looking at the extent of care processes for complex high needs patients, you see that those are less developed or less advanced or less present in those practices that have no Medicaid revenue compared to those that have at least some Medicaid revenue. And we see kind of a similar pattern across the next 3 groups, whether or not you're participating in some type of payment reform program, whether it be ACOs, bundled payment, comprehensive joint replacement CJR model, et cetera. That is less likely if you have no Medicaid revenue. You're also less likely if there's no Medicaid revenue to have registries that you're using across certain clinical conditions. The next one we thought was really interesting, because here we see more of a linear relationship, which is screening for social factors, right? Housing insecurity, Medicaid eligibility, food needs, a lot of different, social drivers. Not only are you less likely if you have no Medicaid revenue, but as you get into these different buckets, you're more and more likely to start screening for these factors as your percentage of Medicaid revenue increases. For the next three, we didn't see as much of a relationship as we did for the first four in terms of patient activation or health information technology exchange capabilities or patient access capabilities. But we did see some differences when we looked at the point estimate that were consistent with our prior findings. Next slide. And then we wanted to limit to just, those practices that were not accepting Medicaid. And we wanted to look at, after risk adjusting or adjusting, for those other factors that we highlighted in that prior slide, like if you were part of an HPHC or urban rural status or percentage of patients who are living in poverty in your area, how that predicted the probability of you not having any Medicaid revenue. And it was pretty similar to our first table, the descriptive table, which, you saw a similar story. If you are an FQHC, if you are rural, if you have a Medicaid expansion state, or if you have more PCPs, part of the health system, all of that is going to increase your probability of accepting Medicaid or at least having some Medicaid revenue. And so that profile of a provider is, again, pretty consistent with what we saw in the first table. So just to get into the discussion, because I want to leave plenty of time for any questions and to open up to the group. So we saw, about 17% of practices that had no Medicaid revenue. That's pretty consistent with some other work that's out there. Again, it's higher when you look at the physician level, but when you limit it to the practice level, about 20% is what we see some in other literature that's come out after our paper. Again, practices that had no Medicaid revenue, on average, tended to be smaller, independent, a higher proportion of primary care physicians, more likely to be urban and in low poverty areas, and in states that have not expanded Medicaid. And some of the reasons for not accepting Medicaid, again, this was not directly part of our survey itself, but was part of follow-up qualitative work that we did after the fact. Some of the organizational capabilities and infrastructure that you may have. You may not have access to you may have access to a large enough patient base outside of Medicaid in terms of private, Medicare, other payers, that you don't feel the need or the financial necessity to take on Medicaid revenue. And you also may have less advanced population health and IT capabilities, as well as other administrative capabilities that we see in smaller independent practices that may prevent you from wanting to take on potentially, at least conceptually, more burdensome administrative and other billing requirements, at least in terms of you may think that's the reputation of the program. And so one other discussion slide, I think, Pam, to get to your point about, we think about this a lot in our group. It's obviously critical and an important topic is how to increase uptake in Medicaid participation among these practices. And as you mentioned, reimbursement rates, it's the first thing we hear, and we hear it all the time. I think there may be some truth to that, obviously, but there's also an incredibly challenging option to implement, especially if those federal dollars are not going to increase, and that is going to come from state funds or other, sources of revenue. With that in mind, I think some other possibilities are to really focus efforts, first and foremost, on those types of practices that are the ones that are not taking any Medicaid revenue at all. Those smaller independent practices, what is it that they need? Is there anything that can be done, right? Can billing and administrative requirements be streamlined and be, simpler for them to do? When you think about monthly enrollment in Medicaid, when you think about, some of the unwinding that may be occurring, maybe not as much as Washington as other states, but, how does that play into then their likelihood of participating in the program at all? Can there be timelier claims processing, right? Can you ensure those smaller practices that are maybe operating more on a monthly basis when it comes to paying bills or getting reimbursed quicker and on time for those Medicaid patients that they're seeing? And is it possible to offer some technical assistance to help them understand, for a different patient population that they may not be as familiar with, what it is that they can do to help care for that for those individuals and those Medicaid participants. I think another approach is when you think about, areas that are residing with more individuals that are receiving Medicaid, they may be more likely to move from that 0 category to 0 to 10% category, or greater than 10% category, right? Maybe that in those particular hot pockets, if whether you're looking at some of your tools, your geographical tools that you may be using, GIS or others, to try to identify hot pockets of both providers and Medicaid participants, whether there you can kind of structure some of those interventions. And then finally, I'm always hesitant to talk about the power of consolidated systems of managed care. There's both pros and cons to that. But, some of those larger systems that have those administrative processes in place, that have the ability to take some of that burden away from practices and providers, in as much as they are not maybe taking care of as much Medicaid patients as they could, it may be helpful to engage them and have conversations with them as well. And so, with that, I'll open up to any questions or any comments, and just want to, again, thank you for the opportunity to present to the group.
Any questions for Stephen? Okay, Roger. You're on mute, my friend.
All right. Thank you, and I want to be careful not to go over my allotted time here, so I'll try to run through these very quickly. Thank you very much for the presentation, and just one comment, as we said. Otherwise, I've been keenly aware in the Medicaid programs for a number of years about access problems and the under reimbursement of Medicaid in comparison to Medicare or commercial. And I would say, for good or bad, that's one of the reasons why a majority of states have looked to managed care. And one of their arguments has been is to try to increase access, if you will, through the robustness and theory of the managed cares network. I'm not sure how successful that is, but that's been one of the strategies. So a couple quick questions for Mike. One deals with what I would call, have you any thoughts on what I'm going to call the study of price elasticity? By that I mean, it's been my experience in the past, you can increase rates a little bit, to try to keep your provider community happy, but you're not really increasing capacity. And the argument's always been, unless you get those Medicaid rates, essentially up to commercial equivalent, you're not going to move the needle. It's sort of that price elasticity argument. And curious in your thoughts on that might be. The other one is, I know you've mentioned about, looking at smaller practices. And I guess I'm kind of curious your thoughts on this one. We're seeing a tremendous consolidation, in the healthcare industry in general. It's going to be there big time in the physician community. So the notion of trying to focus on smaller practices may be, well, how much longer are they even going to be in existence? And might it be better to try to strengthen the larger clinics and or practices there? Because that's where the market's going, regardless of what Medicaid does. So your thoughts about that one? And I'll just do maybe one last one, which is always this issue around, simplifying your billing and payment aspects. I wholeheartedly agree with that. And having worked in the Medicaid program for a long time, our response has always been, well, we don't pay well, but we pay quickly. And I think we have some data to have supported that. But, strategies to try to simplify that. And again, I might look to our own Medicaid program to say, are we consistent with what our state agencies are doing with state employees and the SEB and PEB, to be sure that we're all, in a line of having consistent billing practices to the extent possible to add to that simplification and support. So any thoughts you might have on that would be appreciated.
Yeah. No, I think those are all really good points, and I'll try to address as many of them as I can. There was, to get to the managed care point, there was a recent study, and I'm more than happy to share it with the group after the fact, and I can send it to Angela, that looked at this topic with managed care organizations, in particular Medicaid managed care organizations, and kind of post-Medicaid expansion. And what they were trying to understand, and I think it was University of Minnesota, Hannah Nefresh, who led that work, trying to understand, how providers, when you're increasing Medicaid rolls by, in some instances, millions of individuals, and you've got providers that are hesitant to take them on, how that would actually happen within managed care organizations. And what they found was most post-expansion that were not taking Medicaid patients, or had very few, continued to do so. And that was about a third of Medicaid managed care organizations across these different states that had physicians in those organizations that had them as a payer that were taking very few, nearly zero Medicaid patients. Fewer, they had their category was 0 to 10 Medicaid patients a year. But there were 25% of physicians who operated within that Medicaid managed care environment that saw 86% of Medicaid individuals. And so there was a hyper concentration that got worse, if anything, during Medicaid expansion. And that relationship is something that you see both within Medicaid managed care, but also on the fee-for-service side as well. It's falling more and more on those that are already taking Medicaid patients. And you're not seeing those others that are not kind of soak up the increase in rolls. And so trying to understand why that is and why there's that hesitance, even when you've got higher match rates, higher reimbursement rates, and like you said, that price elasticity or inelasticity, better said, what that cutoff is, I think is up to the debate. And I don't know, and I see Christine on the call, I don't know if you have thoughts on that as well, but it's something that I don't know if there really is an exact answer on that question, unfortunately. And if there is, I don't have it.
All right, I'm gonna jump in, Roger and Stephen, because we have like only 20 minutes to go through our recommendations. And you called out, I appreciate you calling out Christine, because we actually have this on our list of questions. If you're interested, you're certainly welcome to stay and listen to the conversation about that particular topic. But I'm, eager to get back to our consultant and kind of get set up so we can have this conversation. And again, thank you for your presentation, which was wonderful and really appreciated.
Thank you.
So Pam, are you going to lead through this, or are we going to just do this together?
Well, I think we're going to do this together, Liz, and I don't know if you want to set it up and then we'll start working through the questions. How does that sound?
Sure. So just to reground everyone, these were the questions that were sent over to all of you from the commission. I won't really spend any more time on this because we looked at them just at the beginning, and hopefully the presentations today helped kind of get and I think, because I've been listening to this conversation and the questions, I think got everybody's, minds thinking about this. So why don't we go to the next slide? Because I think we really want to have a discussion, and I think we've started to kick it off. And actually, I just want to acknowledge that I do think Roger started kicking off a conversation, particularly on considerations around a waiver with his memo that he sent to all of you in advance of this meeting. So the questions that we, the big question is, integrating Medicaid is different from integrating Medicare and ERISA in the sense that there is a pathway forward through a waiver. And one of the, sort of core pieces is how can the richness of what we see in the Medicaid benefits, as Dan talked about, how that has to be maintained, how can that be preserved for Medicaid eligible individuals while providing, coverage to the broader population. So that's really what we're trying to sort out here. And so I think just to kick it off, based on what we've heard today, what are some of the positive and negative aspects of the Medicaid program that need to be considered and maintained as we think about using, I think actually just one question I want to ask based on what I heard today. Unlike Medicare and ERISA, what does it seem to you, to all of you, that Medicaid is a core element in terms of how the universal system is designed? I just want to ask that question right off the bat. And is there any reason not to include it as that? And unlike where with Medicare and ERISA, we've sort of set it aside for now. And the idea is that we will try to achieve some equity for folks that those are their sources of coverage. With Medicaid, are we seeing something different?
Roger.
So let me just say it this way, if I'm going to try to be brief. In my view, in our state today, Medicaid, when we look across health markets, our insurance markets, Medicaid is the largest single entity in our state. So if we're gonna be doing anything, you know, with universal healthcare coverage or consolidated purchasing, it is a core element that needs to be there. So I guess what I'm trying to say is the answer is yes, and we couldn't really proceed without it.
Yeah.
It kind of, one last thing, I'll shut up. We always have discussion about, there's a richness of benefits, and we'll talk about all that later on. But there's a very easy way of handling this at some point in time, when there's a universal health benefit design in place. Medicaid can fit within that because we cover everything in the Medicaid program, and those benefits that fit out aren't in that could be easily treated as supplemental benefits as a separate component through separate delivery systems that we have in place today. I mean, we do that now. So this issue about benefit, you know, compatibility, in my view, is not an issue only insofar as we're never going to get a waiver that says we're going to restrict the benefits that we're offering today.
Okay.
So,
Yeah. David, did you have a question or comment?
Liz, I'm wondering if you could clarify your question, because we've been talking about a unified system, and I don't think we can have a unified system without Medicare, without ERISA, without Medicaid. And so if you're asking about universal coverage and whether setting aside Medicare and commercial and ERISA and using Medicaid as a vehicle to expand coverage, to me, those are two separate questions. And so that's why I want to try and understand.
Yeah, I think Roger sort of answered the question for me. I just want to make sure that we're asking and answering that question. Is Medicaid part of the vehicle, the core universal system? And do we use it as a starting place?
Okay.
And do what Roger's saying, where we can add supplemental benefits in the other type programs to achieve parity for them.
Yeah, one comment, I think also Eddie's got his hand up, is that, I mean, this is the program in which we have some, you know, wherewithal to do something, you know, because some latitude as a state, and we have a lot of experience. So that I think that's, you know, it may be that it's the driver, what goes first, to David's point that you can't say that doesn't mean we're not interested, or, you know, you can't have a universal system without those other programs as well. I think, David, you have your hand up. Eddie, did you have your hand up as well?
I think I've been going along the same train of thought, but I mean, the opposite without, you're saying that the state would want to go on its own and try to do this. And we heard earlier, you know, becoming a state self-insured entity, you know, those are pretty drastic. So I think going forward, what we heard today with the waiver process and the SPA, those were two vehicles that we have on the table as tools.
David?
So Liz, thanks. I think I understand what you're saying, and I agree with you and Roger. And, you know, one of the ways that I've been looking at it is Medicaid for all as sort of the metaphor, and how do you get there, whether it's, you know, in parts and pieces or some other way. One of the things that is unclear to me, in one of the original UHCC reports, there was a description, I think it was tied to Model A, that one of the objectives is to raise the Medicaid fee schedule, bring down the commercial fee schedule, and unify the fee schedule. I don't understand how that dynamic overlaps with what we learned from Dan. And if raising the Medicaid fee schedule presents so much new cost, it presents a problem for getting a waiver or the authority to use Medicaid as a starting point in the vehicle, because that fee schedule change presents too much increase in expense.
Christine, we haven't heard from you yet today.
Sure, sorry, I couldn't get off mute. Yeah, so I think the Medicaid for All, it sounds like it makes sense in some ways, because you're building from this base, and as Roger said, it's the largest largest population in the state, and you have leeway to do something there. I think it could be a public relations disaster, right, to brand something. And that, not that we would brand it that way, but just in general, I think that this then dovetails with what I think David was saying, is that raising the rates, like trying to doing something to like improve the public perception of what this policy is, might be critical. And I don't think you would need a waiver, because I think the rates are, the state negotiates the rate. Like, I think I need to refresh my memory on this, but there's a wide variability across states in what rates are paid. And, it seems to be up to the state policymakers. And I don't think it's the same thing as requiring budget neutrality.
Right.
Well, I think Roger and Michelle are both on here. I'm sure they can explain it clearly to us. So what it sounds like folks are saying, and please everyone chime in here. We like the idea of starting with Medicaid. It's a strong vehicle. We made their public relations part aside. This issue of reimbursement is something that there is a concern about, and to make sure that there's enough providers to take who comes.
Liz, can I try another one here?
Yeah, please go. This is your conversation.
But let me try this a little differently. I believe the commission is going to go through a process, and benefits are a good example. They are going to design and help them design a uniform system. And as that design process goes on, in my humble opinion, Medicaid is going to be part of it. It's not going to drive it. It's going to be part of it. And so that as they're going through their design process, some folks are going to be, kind of thinking through what do I need to do waiver wise or otherwise to make the Medicaid program compatible with that design. Benefits, let me just try real quick on the benefits, try to explain what I'm trying to say here. I quite know that a uniform benefit design for our state will never include the array of benefits that Medicaid has. The best example is long-term care. It's going to sit separately for a long time. But you can bring in the Medicaid benefits, you just take that package out and put it into this uniform benefit design. And to the extent that we have, issues around rate normalization, because we're going to have to wrestle with that issue at some point in time, the question may be, well, you're going to need, some additional general fund state dollars to bring those rates up. How are you going to finance it? Well, that's an issue over here that can be dealt with. And I'll just say 1115 waivers would not create constraints for that, because one side of these 1115 waivers is what you can do, what would happen absent the waiver, right? With the waiver, without the and you can increase rates. We can say we're going to increase rates up to 100 commercial rates. We can do that today. And you could argue that would not be part of a budget neutrality calculation, because we can do that now absent the waiver. I'm not quite making sense to you, but trust me, we can get there through that vehicle. It's one to finance it. So what I'm really trying to say, Liz, is that Medicaid should be brought in and part of designing the system. And there may be some revisions that need to be done to the Medicaid program to make it compatible with that system. And we'll use waivers or other state plan amendments to get there. We can get rid of asset requirements, for example, right now. We got vehicles to do that. Am I making sense at all?
Yes, I think so.
Okay, sorry. But it does deal with the PR problem. We're not going to say, hey, this is Medicaid for all, and we're gonna make it compatible with Medicaid. I agree, that would be a nightmare. We don't want to do that at all. It's bringing Medicaid into this new vision.
Yeah. Okay.
All right.
So I think just to, and Pam jump in here, but there are a series of votes on Medicaid that are, again, they're starting places. And we really would like the FTAC to think about how we frame this and make this recommendation to the commission. Again, these are starting places, and Roger, I think, provided some considerations and thoughts in his memo, but would like to turn it over to Pam to move us forward through this.
Yeah, so these are the, the votes that are put before us. And we can keep Roger's memo in mind. And I think this is not the last discussion on Medicaid. There's a huge topic that will be percolating up as we talk about consolidation of state programs and benefits and costs. So the first is there a motion to recommend that the commission pursue an 1115 demonstration waiver to include Medicaid enrollees in Washington Universal Healthcare Systems, details of which will need to be developed once benefits and services are determined. It's kind of a formal way of saying what we just discussed. Christine.
Yeah, I just have a question about this because would a waiver, I'm kind of unclear where the waiver is actually necessary. So for example, we just talked that rates could be raised without a waiver. So that's my question is, could this be just equalizing the rates and harmonizing benefits? Could that be done without a waiver? And if so, my thinking is that would be a safer approach because you wouldn't have the vagaries of the administrations coming in and out. It sounded from Dan's presentation like administration might just maybe we've opened the door now to like administrations canceling 1115s. So I guess I'm not clear on that, whether that other option is viable.
I know Gary has a comment and so does Roger, because they know exactly what we need waivers for.
So Christine, I think you're going to need a waiver to include Medicaid beneficiaries in a universal financing system. I don't think you can just automatically, if you want federal funds to flow into a universal financing system to pay for services to be provided for people who would otherwise be in the Medicaid program, you're going to need a waiver. It's not a waiver like the ones that we've been talking about all day to expand coverage to new people or to provide different services. It's just to include those people in the universal financing system. You're going to need a waiver because that's not the way it's working today. Today it's working a Medicaid program. The Healthcare Authority manages the Medicaid program. It's going to be different from what it is today. And so you're going to need CMS to approve whatever new structure you establish.
So you're talking about like the administrative processes of getting reimbursed would have to change.
Yes.
Okay.
Something's going to be different from what it is now, and you're going to need CMS to approve that. And I think the way that we're imagining that would be done would be through an 1115 waiver. It could be done through a state plan amendment. That's another way of doing it. But one way or another, you're going to need to get CMS to approve the change in the, as you say, the administrative structure and how the program is going to be administered. I mean, it might not be the Healthcare Authority. It might be some new state agency that's running the universal healthcare system, right? We don't know that yet.
Right. And we don't mean to exclude other tools or avenues that can be used in addition to an 1115 waiver to bring the programs together.
So, I mean, could this be modified to say 1115 or SPA?
Is that accurate?
Well, a further modification, 1115 waiver as needed.
Or yeah, because maybe the spas in absence of or in advance of getting the 1115, you get a spa for some of it.
Yeah.
Let me just say, I think the key is Medicaid should be part of this design, and 1115s may be a needed tool. State plan amendments could be part of that toolkit, but we want to keep it in the toolkit. And to acknowledge I go back to the commission that unlike Medicare or ERISA, we can bring Medicaid into the universal system. And I'm getting a little ahead of myself, but they're going to start talking about consolidated state agency purchasing in this coming year. And Medicaid can be brought into that transitional system through these mechanisms.
And to Gary's point, that if we do propose to move it over to somewhere else, it's going to need approval.
Sure.
Okay. So
So when Roger, when you're talking about the waiver and the examples that we had today of expanding a certain aspect, it's, you know, adding one piece that wasn't there or augmenting a current piece in a different way. But then when you're using the waiver as this thing that's going to envelop everything, that's the same tool that gets used, but it has so many purposes. And then Dan had spoken to that some states have waivers in place where when they're going through the complex negotiations, that parts of the waiver will be approved and parts won't be approved. And as they get approved, they turn them on. Yeah, this tool is very flexible. Maybe I'm just talking out loud, so.
It's okay.
I think what's hard for all of us is we don't have a design sitting in front of us.
Right.
We had that design there that we say, here's the Medicaid program. How do we make it fit? And if we need to do state plan amendments or 1115 waivers, which give us this flexibility, to your point, and we can do that. But we're kind of a little bit of a problem here is that we don't have basic design parameters to give to the commission more direction on specific waivers. Maybe that's what I'm trying to say now.
Right, that we can't be that prescriptive without having the plan in place. But I think there was a demonstration waiver as needed, I think is what someone said. Is that an appropriate way to go?
Or you could even make it more general to say waivers and spas as needed.
Oh, I like that better. That's more flexibility.
I think Dan's comments too about the long-term care pieces, who knows that when we're talking about separating out populations, what that's going to look like. So I think being as flexible as possible.
Yeah. Okay.
And the spa, when we're looking at the universal system, it seems like the spa was more at a targeted, so the waiver that they were, you know, targeted to a specific group or a specific service or redefining that. So a spa was as well, but then a spa that would be on the top of all our current waivers. I didn't envision that. I didn't understand that.
Can I give you an example very briefly and I'll shut up? Today we have asset tests for something called categorically needy, aged, blind, disabled. We want to get rid of asset tests. We can do that today under a state plan amendment. We don't need the 1115 waiver to do that. So that would be an example. If we're saying for this new system, we don't want to have asset or resource requirements, okay, let's say that's the decision made by the folks. We can say, fine, we can go after that specifically with a spa. We don't need a waiver to do that. Other things we may, as we see that design's more clear.
And all I thought about is if you do that, doesn't that mean that then the federal government has the right to say, well, you know, these people do get the match and these people don't get the match because you're taking on the responsibility
of
those that don't. Okay.
It's under the waiver.
Okay.
Pam, can I ask one last thing? And I promise I'll shut up completely.
No, you don't have to shut up.
This is universal health system. And could we put in print there something about the discussions about consolidated state purchasing? Because that's kind of a step before.
On the first one, I think that I consolidate, no, but I defer to the group. I'm concerned about you wanting to add consolidated state purchasing into the first one, into the first vote.
We have other ones we can include it in.
I just feel like it changes it too much. It's not that I disagree with consolidated state purchasing, which may be absolutely necessary to get where we want to go. It just would be.
I withdraw my comment.
Okay. I mean, I don't want to step on when anyone thinks about this, but that would be my recommendation, is that we bring in the consolidated purchasing on another one. Are people comfortable with the first vote with these modifications that we discussed? Anyone have concerns? All right. I think Liz, we may have done the first one. Do you want to move to the second?
So maybe it's demonstration waivers because
it's waivers and spas as needed.
A plural, but yeah.
Oh, okay. Does that help? I think that's I think that I like the idea of giving the commission maximum flexibility as well. Okay, is there a motion to recommend that in their transitional solutions work, the commission consider paths to simplify administration for the Medicaid program, which may help motivate provider participation in Medicaid?
Oh, can we move to the next slide? Sorry, we're still on the. Okay, so this is the second vote in
Yeah.
recognition of the need to make sure that that Medicaid is part of the rebranding effort, I guess, is that there are providers willing to accept Medicaid. One of the things that we heard Dr. Spivak, and we've heard from other folks actually a lot in recent years, is that accepting, it's not just about payment, it's also about how complicated it can be as a provider, especially to treat folks with complex health conditions. So that the intent of this vote is really to focus on giving the commission, as is planned, reinforcing that they are looking at efforts to simplify administration for Medicaid, which eventually will motivate participation in Medicaid and with the growth in the potential population under a universal system. So does the is this a vote that the FTAC would like to make? Roger and David.
David, go ahead, please.
Oh, thanks, Roger. Liz, it seems to me that the reimbursement issue is larger than the administrative issue. And I'm wondering, are we purposely avoiding that issue because somebody else is thinking about that? Or, why are we not recommending that reimbursement rates increase?
Well, why don't we go to the next slide, because NT is out of order.
Yeah, because
Oh,
we just want to make sure that we're covering bases.
got it. I didn't see that one.
Oh yeah, no problem.
You're a step ahead, David.
Friday at 4:30, so. So this one is related to the reimbursement rate issue. And really just want to continue on the conversation. I know we're at time, but want to make sure that we continue what we were discussing after Dr. Spivak spoke.
I think what Roger pointed out here, that this is a smaller and smaller group that are the smaller independent physician group.
Yeah,
I agree with you. I think we may want to broaden this to not name those groups, but maybe say to physician groups as appropriate or something.
Yeah, I have something, this is not facilitation, this is, to contribute to the discussion, is I think there are a lot of issues related to access and provider groups. And there's also access to specialists, which has always been a problem within Medicaid. And there's access to certain populations that, so I think I would be comfortable if we could broaden this somehow to kind of better define the problem before we, had a specific recommendation about targeting improved reimbursement.
I mean, some type of payment structure that allows for those that are in the 0 to 10 to get a better compensation package than those that are in the massive size that are in the higher percentages and have the administrative and capacity to deal with it. They get the normal. I don't know.
Roger?
Well, hey, I'm kind of following with you. One of the proposals I guess I would suggest, I mean, we're talking about this area of Medicaid payment rates. It's a no-brainer that Medicaid rates are lower than everybody else. I think the question I would ask or suggest back is that the commission direct a study to say, where are those differences? To do actually a rate comparison.
Mm-hmm.
And that's going to some degree, and where we have access problems, and that's going to kind of define where we go with respect to dealing with the issue about Medicaid rates. I'm going to try to give one small example. The biggest provider for the Medicaid program are FQACs, Federally Qualified Healthcare Centers. They're paid essentially what almost would be commercial rates. just as one small example, the way we pay him today, we would know that unless we had this sort of this comparison to find out where those deficiencies are in the rate structure. And to do some estimates, but say, okay, we got that. How much is it going to cost to bring those up? It's kind of part of that rate analysis question that I have further down that list. I'm sorry. I think it's.
So Roger, if I hear you correctly, you're suggesting, so what I feel like I've heard from everyone is that it needs to be broader. It shouldn't be just from a few folks I've heard, it needs to be not targeted at this point because we actually don't have enough information to understand where the access issues really are.
Well,
and we need a study to look at it.
Yes, particularly as it relates to rates.
Yes.
And I think Christine tried coming off mute just a moment
sure.
ago. Christine,
Go ahead,
did you?
Christine.
I just also would second the study idea. I think we also maybe haven't thought through all the consequences. So like having a threshold of 10 could lead to like changes in practice size. You know, there are a lot of gaming things that could happen. So I think we need to think that through.
I also, I would like to, I don't know if Bob, if you have any comments, I know that you've dealt with this a lot, rates and things like that, and have some thoughts. If you have anything you want to say here.
With regard to rate levels, you mean,
Or just how having some language around how the commission should consider this issue.
Yeah, well, I'm hesitant. I don't know a lot about physician fees, but for hospital payment levels, both Medicare and Medicaid payment levels are thought to be low or inadequate. And for hospitals, again, I don't know how much this transfers to the logic transfers to physician payment and just general level reimbursement levels. But for hospital, Medicare and Medicaid rates are adequate for efficient hospitals. That I don't know that you can extrapolate from that logic to say that's the case for physicians.
Right.
But there's that question out there is like, have we just bid up input costs across our health system, both hospital and non-hospital, such that it looks like Medicare and Medicaid rates are too low when in fact input costs are just way too high. That's the case in the hospital industry. So I, maybe that you want to try to do some analysis to see relative to physician input costs, whether, how inadequate Medicaid rates are. And then again, my expertise is more for hospitals. For hospitals, you have Medicaid payment rates that are considered low, but they get all these other supplemental payments. You have to factor that in. I'm not expert enough on physician reimbursement to know whether that dynamic applies as well. So I have some skepticism about this overall, sense, which most providers discuss, that Medicaid rates and Medicare rates are too low. I'd be a little skeptical about that. I don't know if there's some analysis could be done to sort of push that question a little further, but that would be my only.
Okay. Sorry to call on you like that. I think,
no, that's right.
But I think the point of needing to have some more information analysis, which is I think what you're saying, Christine, we need to be broader, but we need to investigate further where reimbursement is an issue, because we just don't know enough.
Right, and we need to know more specific to Washington State.
Exactly. Okay.
Yeah, I would support that. A little more intelligence, and don't just take for granted what all providers are saying, because there are caveats.
Okay.
So the language would perhaps be motion to recommend that the commission investigate or pursue analysis to understand reimbursement for physicians or providers. Trying to come up with some language here, providers, and how that impacts their willingness to accept Medicaid beneficiaries.
I think that's good.
Okay, so we'll put something like that together and send it out, but it's the general idea is that we need to look further and not have it be so specific.
Yeah, I think since we're tweaking all of them, we can redistribute.
Sure. Okay, and then the third sort of more scripted out vote that we have is this one around just reemphasizing that the commission in their transitional solutions look at admin simp for providers and how that could increase participation. It's unclear, I think maybe the investigation that we're talking about could could also look at this question as well.
Seems like there's a technology solution in the future for this one. I don't know.
Any issues with making this recommendation, though?
Roger, did you have something?
Very, very briefly, when I'm seeing administration, and Liz, it's not about dealing with complex patients. That's a fair issue. But when I'm reading about this, it says to me is the relationship between the provider, if you will, and the payer. Let's say the healthcare. Okay, on that one. And maybe one way of kind of attacking this, and I'm getting too specific now, and I don't mean to do it, but is quite frankly, just looking at a comparison. How does our Medicaid program look in comparison to UMP, as an example?
In terms of administration.
Yeah, and that's side. And just one of the things that come add a complexity here, which I don't mean to do, but typical Roger, 85% of the folks in Medicaid are in managed care. So that provider's relationship isn't with healthcare authority, it's with a carrier.
Yeah.
And so maybe part of this analysis needs to say is, are we requiring there to be, consistency across the carriers we contract with and how we're doing to try to make that a more simplified system? I'm muddling the waters here. I don't mean to do that, but it's.
So you think that the MCOs are being overly burdensome to?
I have no idea. It's a great question. I don't know. I should know our own Medicaid contracts, and I don't know what we tell carriers about their billing procedures.
But the MCOs submit back to HCA.
Yeah, they submit payment information, but we're not for claiming purposes. But the billing relationship is between the carrier and them.
Yeah.
So I think it's a great one to look at it. All of a sudden we start to grab it. This thing's getting a little bigger all the time, but I think it's an essential one. I think the both of us saying that, this is a technology one, but we ought to have standardized billing procedures across all payers in our state on that administration.
And I know there's been efforts to do that in the past. So maybe we need to just say simplify administration for the Medicaid program and spell out, between, that it's not just the providers and the MCOs, it's the MCOs and the state, and to just kind of get a full picture of exactly what's going on here.
Yes.
Okay. So
Liz,
Rob,
I think it's fine as written, because you're
Okay.
just talking about considering paths to simplify administration.
Okay.
That's a pretty broad umbrella, and at least being on the MCO side, we when we approach a provider group, we approach them for all lines of business, so their credentialing is the same across all lines of business. So I think what this might entail is, if you're specifically talking about Medicaid, you have one provider that has to deal with 5 different MCOs, depending on what county they're in. So I think there are valid arguments or questions in here, but I think the way you've written it allows us to cover the breadth of questions Roger pointed out.
are folks comfortable with this language? Okay.
Any concerns? No, it doesn't look like any concerns.
Okay. And then the next vote was the blank one. And is there something that needs to be considered from, again, from Roger's list, or anything that you've heard today that we need to make sure that is reflected in the guidance to the commission on Medicaid?
Liz, is this one we may have time to chime in on when you recirculate? I don't have anything off the top of my head, but I could imagine there might be something we want to consider.
I see Roger's hand.
So I have a suggestion. I'm so sorry to do this. At the end of the day, I brought along, there's a list behind all of this, which we really don't have time to look at. A suggestion might be is to say, given what we've approved now, and looking through that, that list that's an attachment to that, is there anything else that folks would like to recommend to be included in the recommendations back to the commission at this time? And maybe we can vote on it somehow just by an exchange and say, yeah, we want to add 2 or 3 of these or none of them. But we have time to kind of at least ponder those. Am I making-
Your list?
Yeah.
Well, and I mean, I would also argue or suggest that many of these things actually, I think Pam said it well. This is not the only time we're going to be talking about Medicaid. Through the course of our year, we'll be talking about, in the next meeting when we come together, we're talking about benefits. We're going to be talking about Medicaid benefits. So we will be coming at Medicaid over and over again because it's going to be a core component of how we're designing the system.
Yeah, I really like how you said that, Liz. I think that we need to reserve the right to circle back on the Medicaid topic several times, because I think if we talk about consolidated state purchasing, which is going to come up when we talk about benefits, then we need to come back. So that I think, Roger, that will catch a lot of the issues that you brought up.
Yeah.
I feel apologetic that we didn't have more time for this discussion. I think there was more fluidity on some of these recommendations than I saw initially. So, but it makes me feel better to think we can come back to them.
So should we have a consideration or motion that basically says the FTAC, the commission should continually, have the flexibility or continually revisit issues around Medicaid as they come up through other conversations around, benefits, cost sharing, et cetera, et cetera.
Yeah, and I just think Medicaid is too big and too central to what we're trying to do to not revisit it on several occasions.
Okay.
I don't think you need a motion for that. I think you can just include that in your memo.
Okay.
Yeah, I think so too.
Okay.
I would like to, whatever we send to the commission, I would like to send around to the group if we can.
Of course.
We will.
We made so many tweaks and changes. I think it's important everybody has another chance to look at it.
Absolutely. We will. I think Angela and Mandy, we can talk about trying to get a draft of something next week and start circulating it around to folks and getting it where it needs to be.
Yep. That sounds good.
All right. Did we do it?
Yeah, Marty, you can go to, if you don't mind going to the very last slide or second to last, it says next steps. Yep, perfect. Thank you.
Yes, and I think the important step is to circulate the language, and then that will be shared with the Universal Healthcare Commission in February.
Yes. So there would be like a second out of 3 bullets saying this is going to come to the FTAC before it goes to the commission. So you can see how we're capturing your discussion. Awesome.
Okay. Okay, good work, everyone, today. I think great discussion. And I think that we should think about making sure we have a little bit more time for discussion, because I actually don't think that people were talking a lot. I just think that these are really big topics and they probably deserve a little bit more time. So it's always hard to balance between the presentations and the discussion. We'll keep working on that. Thank you, everyone, for your time, and thank you to staff for the hard work in putting this together. And we had really excellent presenters today, so it was great. Thank you.
Thank you.
Thanks, everyone.
Thank you all. We'll see you in March.
Yeah.
Bye.